Welcome to Lesson 12. In this lesson, we will begin ICD-10-CM Chapter 9, which covers diseases of the circulatory system, coded from I00 to I99. This lesson is for educational purposes only. Please refer to official ICD-10-CM guidelines. Lesson objectives. In this lesson, we will focus on hypertension coding rules, hypertensive heart disease, hypertensive chronic kidney disease, combined hypertensive heart and CKD codes, secondary and resistant hypertension, hypertension-related complications. This section builds the foundation for CAD, stroke, and AMI coding. Chapter 9 Exam Importance. Chapter 9 is a high-weight chapter in CPC and CCS exams. It heavily tests combination codes, the with guideline, sequencing logic. One small documentation detail can completely change the code. The with guideline, most important, ICD-10-CM presumes a causal relationship between hypertension with heart disease, hypertension with kidney disease. Because these conditions are linked by the word with in the alphabetic index, they are coded as related, even if the provider does not explicitly state the relationship. The only exception is when the provider clearly documents that they are unrelated. This rule is extremely important for exams. When provider link is required. For conditions not linked by terms such as with, due to, associated with, a relationship must be clearly documented by the provider. If there is no documentation linking the conditions, they should be coded separately. Never assume relationships outside the with guideline. Hypertension with heart disease, I00. Assign a code from category I11 hypertensive heart disease when the patient has hypertension and heart conditions such as heart failure, myocarditis, cardiomegaly, other ill-defined heart disease. The relationship is presumed unless stated otherwise. Additional codes with I11. When specific heart conditions are present, assign I11 first. Then assign an additional code to identify heart failure, I50, or specific heart disease from I51. Always check whether an additional code is required. Heart conditions that do not need extra code. For certain heart conditions, such as myocardial degeneration, I51.5, cardiomegaly, I51.7, only I11 is assigned. No additional heart condition code is needed in these cases. This is a common CPC exam trap. Unrelated heart disease plus hypertension. If the provider documents that the heart disease is not related to hypertension, assign I10 or I15 for hypertension. Assign the heart disease code separately. Sequencing depends on the reason for the encounter. Documentation always overrides assumptions. Hypertensive chronic kidney disease, I12. Assign I12 hypertensive chronic kidney disease when hypertension is present and chronic kidney disease is present. The relationship is assumed, unless the provider clearly states the CKD is not related to hypertension. CKD coding with I12. When using I12, always assign an additional code from N18 to identify the stage of CKD. If acute renal failure is also present, it must be coded separately. Hypertensive heart plus CKD, I13. Assign I13 hypertensive heart and chronic kidney disease when hypertension, heart disease, chronic kidney disease are all present together. In this situation, prohibited to not assign I11 or I12. I13 replaces both. Additional codes with I13. With I13, also assign I50 if heart failure is present, N18 to identify CKD stage. If acute renal failure is present, code it separately. Hypertensive cerebrovascular disease. For hypertension with stroke, first assign the cerebrovascular disease code, I60-I69, then assign the hypertension code. This sequencing is exam tested. Hypertensive retinopathy. For hypertensive retinopathy, assign H35.0 for the retinal condition, plus a code from I10-I15 for hypertension. Sequencing depends on the reason for the encounter. Secondary hypertension, I15. Secondary hypertension is caused by an underlying condition. It always requires two codes. The underlying cause. A code from category I15. Sequencing depends on why the patient is being seen. Transient hypertension. Use R0 3.0 for elevated blood pressure without a hypertension diagnosis. For pregnancy-related cases, O13. For gestational hypertension. O14. For preeclampsia. Never use I10 for transient or pregnancy-related hypertension. Controlled versus uncontrolled hypertension. The terms controlled and uncontrolled do not change the code category. Both are coded using I10 I15, based on the type of hypertension present. Hypertensive crisis, I16. Assign I16 for hypertensive urgency. Hypertensive emergency. Also code the underlying hypertension, I10 I15. Sequencing depends on the encounter reason. Pulmonary hypertension, I27. Pulmonary hypertension is coded to category I27. For secondary pulmonary hypertension, code the associated condition or adverse drug effect, if applicable. Resistant hypertension, I1A.0. Assign I1A.0 when the provider documents resistant hypertension. Sequence. Specific hypertension code first. I1A.0 as an additional code. CAD plus angina combination codes. The most commonly tested combination codes are I25.11 atherosclerotic heart disease of native coronary artery with angina. I25.7 atherosclerosis of coronary artery bypass graft or transplanted heart with angina. In these codes, angina is already included, so no additional angina pectoris code is needed. CAD plus angina, causal relationship. ICD-10-CM presumes a causal relationship between coronary atherosclerosis, angina pectoris. Unless the provider clearly documents that the angina is due to another cause, you should assume the angina is related to the coronary artery disease. CAD plus acute MI, sequencing. If a patient with known coronary artery disease is admitted for an acute myocardial infarction, the acute MI must be sequenced first. The coronary artery disease is coded as a secondary diagnosis. This sequencing rule is commonly tested in exams. Intraoperative and post-procedural. To assign codes for intraoperative or post-procedural cerebrovascular accident, documentation must clearly show a cause and effect relationship. The stroke must be directly related to a surgical procedure or a medical intervention. If this relationship is not documented, do not assume it. CVA coding depends on. Correct code assignment depends on whether the stroke is an infarction or hemorrhage, whether it occurred during surgery or after surgery, the type of procedure performed. Clear provider documentation is mandatory for correct coding. What are sequelae? I69. Sequelae refer to neurologic deficits that persist after the acute phase of a stroke. These deficits occur after conditions coded to I60 through I67. Common examples include hemiplegia, aphasia, dysphagia. Using category I69. Category I69 is used to identify residual neurologic deficits caused by a previous cerebrovascular disease. These deficits may be present from the onset or may appear later after the stroke. Dominant, non-dominant side, I69. Some I69 codes specify hemiplegia, hemiparesis, monoplegia. For these conditions, you must identify whether the dominant or non-dominant side is affected. Dominance default rules. If dominance is not documented, use these defaults. Ambidextrous patient right pointing arrow dominant. Left side affected right pointing arrow non-dominant. Right side affected right pointing arrow dominant. These are the same rules used in the nervous system chapter. Using I69 with I60 I67. Codes from I69 may be assigned together with current stroke codes, I60 I67, when a patient has a new stroke, and residual deficits from a previous stroke. This situation requires both categories. I69 vs C86.73, very important, use I69 only when residual neurologic deficits are present. Use Z86.73 for personal history of TR cerebral infarction. Without residual deficits, never assign I69 if no deficits exist. AMI overview. Acute myocardial infarction coding depends on the type of MI. STEMI versus NSTEMI, the 4-week time frame. Rules for subsequent MI. These concepts are heavily tested in CPC exams. Type 1 AMI, STEMI and NSTEMI. Type 1 myocardial infarctions are coded as I21.0, I21.3 for STEMI. I21.4 for NSTEMI or non-transmural MI. When documented, the site of the MI must be coded. STEMI and NSTEMI conversions. If a NSTEMI evolves into a STEMI, you must code it as STEMI. If a STEMI converts to NSTEMI after thrombolytic therapy, it is still coded as STEMI. 4WEEK rule, very important, for encounters occurring within 4 weeks of MI onset, continue using codes from category I21. After 4 weeks, ongoing care right pointing arrow assign an aftercare code. Old or healed MI right pointing arrow assign I25.2. AMI unspecified. Use I21.9 for an unspecified acute myocardial infarction. If STEMI is documented but the site is not specified, assign I21.3 STEMI of unspecified site. NONTRANSMURAL, subendocardial MI. If an MI is documented as non-transmural or subendocardial, it is coded as NSTEMI, I21.4, even if a specific site is documented. Subsequent MI, I22, assign a code from category I22 when a patient has a new type 1 or unspecified MI occurring within 4 weeks of a previous MI. In this case, both I21 and I22 must be assigned. When not to use I22. Do not use I22 for type 2 MI, type 4 or type 5 MI. These types are coded using I21, A1 or I21, A9 only. Type 2 MI, I21, A1, type 2 myocardial infarction occurs due to demand ischemia. For type 2 MI, code the underlying cause first, if applicable. Then assign I21, A1. Do not code type 2 MI as STEMI or NSTEMI. Other MI types, I21, A9, assign I21, A9 for type 3 MI, type 4A, 4B, 4C MI, type 5 MI. Always follow the code first and code also instructions. MI with microvascular dysfunction. Assign I21. B for myocardial infarction with coronary microvascular dysfunction. MINOCA with microvascular disease. This code is specifically designed for these clinical situations. Chapter 9 Common Exam Traps. Common exam mistakes include ignoring the with guideline, coding angina separately with CAD, selecting the wrong MI type, forgetting the 4-week rule, using I22 incorrectly, confusing I69 with Z86.73. Quick exam recall. Remember these key points. Hypertension with heart or kidney disease is presumed related. I13 replaces I11 and I12. CAD with angina uses combination codes. Stroke deficits are coded with I69. MI within 4 weeks uses I21. Subsequent MI rules are strict.